All right, future surgeons, welcome. This is your high-yield mission briefing on mastering perioperative pulmonary risk. If you really want to ace your exams and, more importantly, keep your patients super safe, this is the playbook you absolutely need. So let's jump right in.
You know, as surgeons, we get so focused on the operation, right? The cutting, the sewing, but the real battle for the lungs, that thing kicks off the second anesthesia starts, and it keeps going long after we've put the last stitch in. Our main mission is to protect them when they're at their most vulnerable.
So how do we do it? How do you get ahead of the game to prevent a total disaster? Well, it all boils down to understanding one single fundamental change in physiology that really drives all the potential complications. This is the absolute bedrock you have to build on.
Okay, let's break down what is actually happening to the lungs the second that patient goes off to sleep, because if you get this mechanism, everything else that follows will just click into place.
First, we have to talk about something called functional residual capacity, or FRC. The easiest way to think about it is to imagine the lung is a skyscraper. The FRC is like the stable middle floor. It's that volume of air just sitting there after a normal breath out, keeping the building from collapsing, and acting as your emergency oxygen tank.
Now here's the kicker. The second we give general anesthesia, that FRC floor plummets by a huge 15 to 20%. I mean, this is not a tiny little change. It is a dramatic collapse in the lung support structure and its oxygen reserve, especially in those lower dependent parts of the lung.
And this picture shows you the core problem perfectly. So in our skyscraper, there's also a basement, right? That's the closing capacity, the point where the small little airways start to snap shut. When anesthesia makes that FRC floor drop below the basement, those airways just collapse. Blood is still flowing past, but oops, it can't pick up any oxygen. That, my friends, is a shunt, and it's the direct cause of hypoxemia. And listen up, here is a major board trap warning. For your exams, it's not going to be enough to just say, anesthesia causes atelectasis. No way. The answer that gets you all the points is the one that explains the mechanism. You have to say, general anesthesia reduces FRC, causing it to fall below closing capacity, which leads to airway closure and a shunt. That right there is the language of a top scorer.
Okay, so now that we get the why, we can start to name the specific bad guys that pop up because of it. We call them postoperative pulmonary complications, or PPCs. And you have to know them because these things can literally double a patient's mortality risk and keep them in the hospital way, way longer.
So here they are, your four key villains. You've got atelectasis. That's the lung collapse from the FRC drop we just talked about. If that gets bad, it can lead to pneumonia, which can then get even worse and progress to full-on respiratory failure where the patient needs to be reintubated or even ARDS.
Now, this table highlights a super important distinction, especially for your boards. While atelectasis is by far the most common thing you'll see, it's actually pneumonia and respiratory failure that carry the highest risk of death. They are the deadliest villains in this lineup, for sure.
And where you cut matters a lot. You have to remember this hierarchy. Thoracic surgery is the absolute highest risk. Then comes upper abdominal, then lower abdominal, and way down at the bottom is peripheral surgery. Just think, the closer you get to the diaphragm, the bigger the hit to the lungs.
So we know the mechanism, we know the villains, but how do we actually figure out a specific patient's risk before we even walk into the operating room? Well, for that, we're going to use the most important tool for your boards, the ABSITE score.
Okay, the ABSITE score is pretty simple, but it's incredibly powerful. It just combines 7 key things. But you got to pay attention to the heavy hitters. Look at this. A pre-op oxygen saturation of 90% or less? Boom, 24 points. A thoracic incision? Another 24 points. Just those 2 things alone can shoot a patient straight into the high-risk zone.
So you add up the points, and it puts your patient into one of 3 risk categories. And just look at the jump in risk. A low-risk patient has about a 1% chance of having a problem, but a high-risk patient with a score of 45 or more has a mind-blowing 42% risk. That's not just a number, that's a bright, flashing red light telling you to make a plan.
And here is your high-yield Pearl alert. A high ABSITE score is not a reason to cancel the surgery. Let me say that again. It is a reason to have a really, really good, proactive plan. It means you pick up the phone, you talk to your anesthesia colleagues, and you say, hey, let's do lung protective ventilation, let's add some PEEP, and let's plan on getting this person on CPAP early to keep those airways propped open.
So for those patients we flag as being higher risk, especially the ones with known lung problems,
A pre-op tune-up isn't just a nice thing to do, it is absolutely critical.
For your exams, you've got to know the latest guidelines. For COPD, it's easy. Just remember the ABE ladder. The big news is for those Group E patients, the ones with lots of flare-ups, they now recommend dual long-acting bronchodilators. And for asthma, the huge change is that we're moving away from just using a SABA, a rescue inhaler by itself. The preferred choice now is a combination inhaler with a steroid and formoterol. And why is that? It's because it treats both the airway tightening and the inflammation underneath it all, which means much better control long-term.
Next up, you absolutely have to screen for obstructive sleep apnea. Stop Bang is your go-to tool here. The bottom line is this: if a patient scores a 5 or more, you have to treat them as high risk for airway collapse, especially when they get pain meds or sedation after surgery. That means you're going to use fewer opioids and get them back on their home CPAP machine ASAP.
Okay, now for the highest stakes game of all, figuring out if a patient can even handle having a piece of their lung taken out. This is not a guess, it's a very specific multi-step process.
Let me be crystal clear about this, because it's a favorite exam question. FEV₁, that just tells you about the plumbing, how well air moves. But DLCO, that tells you about the actual function, how well gas gets exchanged. You can have a patient with decent airflow but terrible gas exchange. DLCO is almost always the more important number for predicting who's going to get into trouble.
And this 3-step algorithm is the standard of care. It's like a gauntlet. Step 1, you calculate their predicted post-op FEV₁ and DLCO. If both numbers are looking good, over 60%, you're probably okay to proceed. If they're in that middle ground, that 30 to 60% range, then you move to step 2, simple exercise tests like walking up a few flights of stairs. And if their numbers are really low, less than 30%, they go straight to the final boss, a full cardiopulmonary exercise test, or CPET, to get a precise VO2 max.
Okay, last section. The patient is in the hospital, surgery's done. What are the things we can do that are actually proven to prevent these PPCs? Let's separate the real science from what we just do out of habit.
Look, the evidence here is really clear. The winners are lung protective ventilation with low tidal volumes, really good pain control so the patient can actually take a deep breath, getting them up and walking early, and using CPAP ahead of time on high-risk patients. Now, notice what's over on the other side, the incentive spirometer. When it's used all by itself, the evidence that it does anything is really weak. So all that time you spend hounding patients to use it, if that's the only thing you're doing, you're not really moving the needle.
And there you have it, the whole mission, right here on one screen. General anesthesia drops FRC, which causes a shunt. You know your PPC villains and how to use the ARISCAT score. You know how to tune up your patients beforehand. You know the 3-level algorithm for lung resections, and you know which prevention strategies are the real winners. Go ahead, pause here, take a screenshot, burn this into your brain for exam day.
You all did some fantastic work today. Seriously, mastering this playbook is a huge step toward crushing your boards and, honestly, just becoming a safer, smarter surgeon. Stay sharp, and we'll catch you on the next high-yield briefing.